Good. All right, so let's get started so that way we don't go over. Oh, I'm getting a lot of feedback. All right, I hear somebody else. All right, so we're going to be going over some common pediatric dermatologic conditions. I chose to focus more on rashes because that's what you're going to see a lot more of. But given that this is a subspecialty in itself, it's difficult to cover everything we need to in an hour, but I'm going to try and focus on what you're going to see on your boards. So we all have seen a difficult rash and it's 3 a.m., right? And you're like, oh my gosh, I don't know what the hello this is. And I'm trying to figure out what it is. So I'm going to call my attending, right? So there's a couple of key points that you need to know. You've got to know the lingo of how to describe a rash. And I'm serious when it comes to this because even if you don't know what the diagnosis is, knowing how to describe the rash itself can typically lead you to what the diagnosis is. It makes describing it to your attending, it can help them visualize it in their head. It helps you if you want to try and Google different things, put it up to date, look in a book, whatever. Knowing how to describe it is key. I can't stress this enough. Learn how to describe a rash. And when it comes to describing a rash, you want to know what the primary morphology is. And we're going to go over this. How big is it? Is it less than a centimeter? Is it bigger than a centimeter? What's the demarcations of the rash? Can you really tell where the rash ends versus where it begins? What's the color of the rash? You may not think it, but there's tons of different types of colored rashes. What's the distribution of the rash? Is there any secondary changes that are associated with the rash? And so once you really kind of nail this down, that'll help you both on the boards, real life, each other, trying to figure out what type of rash you have. So first, let's start off with more like the primary morphology. So one of the things that you have to figure out is, okay, is it vesicular versus non-vesicular? Vesicles are circumscribed, elevated, fluid-filled lesions that are less than a centimeter in diameter. These can be intradermal or subepidermal in origin. They contain clear fluid as opposed to a bulla, which is greater than 1 centimeter. They're typically thin-walled, they rupture easy, but a bulla is greater than a vesicle. So that's step number one in figuring that out. As opposed to a pustule, which is very similar to a vesicle and a bulla, but these can contain purulent material. These can oftentimes be cultured to figure out what it is. They may be white, they may be yellow, green, they may have blood in them. So there's all different types of colors, but a pustule is different in the fact that it's not containing serous fluid. So keep that in mind. Those are more of your raised lesions. And also a pustule may have like an erythematous base around it as well. Then we go to a macule. So a macule is a lesion that has an abnormal change in normal color of the skin, but it has, the key point here is it has no skin elevation. And it doesn't have any depression associated with it, so there's no atrophy, and it's less than a centimeter. This is important to know because when you come to the next lesion is a patch. So a patch is similar to a macule. It has no depression, no elevation, is a flat lesion, but a patch is greater than 1 centimeter. So we oftentimes will see macules and patches especially this color. This is more like a cafe au lait spot um, with various macules around it, but you can see the diameter of this one's greater than 1 centimeter as opposed to the various macules that are less than a centimeter. So if you get greater than a centimeter, it's called a patch. Next, you have papules. These are more of your raised lesions. They are solid. They have distinct borders. They're less than a centimeter. They may be umbilicated. Um, they may move. So that's important to note as well. Next, you have nodules. So with nodules, think of them as papules, but big. They are solid raised lesions that may or may not have distinct borders. Typically, they will. The ones that don't have distinct borders are typically subcutaneous. And because you can have two different types, you can have subcutaneous nodules or you can have intradermal. To be able to tell the difference between the two, a subcutaneous nodule is typically going to have, if you try and move the skin will move over it. And so it's not in the skin, but if the nodule moves when you try and move the skin, that's going to be an intradermal nodule. And so you can kind of see some of the two differences here. This is a subcutaneous nodule on the ankle as opposed to an intradermal one that's on the forehead. Think of neurofibromas as intradermal. That's the best example I can think of off the top of my head. Another raised lesion that you will encounter is a plaque. These are solid, they're flat topped. They have very distinct borders most of the time. And they're greater than 1 centimeter. Think of these as a intradermal nodule that meets a patch. That's the way I tend to think of these. This picture right here is a good example of psoriasis. Psoriasis typically has plaques. Next, another raised lesion is a wheal. So think of wheals as your classic hives. That's exactly what they are. They are not permanent. They are typically caused by edema in the upper dermis. So it gives you this raised, almost flat topped lesion. They typically are not going to be as big as a nodule. So, or have the changes quite like a plaque. This is an example right here, as you can see nicely, of dermatographism. So what you have is you have histamine release from moving a pencil or finger over an area on the skin that causes histamine release. And so thus you get hives that are shaped in like what you draw. Next, we have the color. So the colors that you can see when describing rashes is you have browns, you have yellows, you have reds. With the reds, is it a bright red or is it a dark red? That makes a difference. Is it blanching? Is it not blanching? You can have tans, you can have blues, you can have blacks. So all those colors make a significant difference. Then we get to the distribution. So is it acral? Is it on the, what I mean by that is it on the arms and just the legs? Is it central? So the trunk and abdomen? Is it generalized? It's all over the body. It's not just in one fixed spot. Is it on photoexposed areas of the skin? Is it dermatomal in its distribution? So remember your dermatomes because they can be very helpful. So what are the arrangement of the lesions? Are they discrete? Are they linear? Are they curvilinear? Are they whorled or parallel? And I say this because when we talk about curvilinear or whorled, they can follow with something called lines of Blasco and some differentials that you need to know about that. They can be an epidermal nevus, they can be nevus sebaceous, hypomelanosis of Ito, Stallworth loves that one. Incognita pigmenti, that'll be on your boards and has 4 different phases that we'll kind of go over. Gault syndrome, Conradi-Hunerman ichthyosis. And if you see these are typically associated with syndromes, as you heard about, and so you need to assess these children for visual and neurologic abnormalities that they may have. And then we get into the secondary morphology. So do you have atrophy of the skin itself? Is it thin? Is the subcutaneous tissue underneath it atrophied? Do you have erosions or oozing that are coming from it? Do you have crusting? Is there a scale? Is it just a single scale or multiple scales? Do you have excoriations? Do you have fissures? So those are important to kind of know. All right, now that we have our lingo down, per se, let's start talking about some of these rashes. So the first thing we're going to talk about is our baby rashes. We all love our babies, but they tend to have lots of different rashes, okay? And it's important that you know what these rashes are. Most baby rashes are going to be normal. There are some pathological ones, but the common ones themselves are going to be normal benign rashes. So the first one we have is cutis marmorta. So this is a normal rash, is a transient vascular change within the dermis itself. It's a response to cold. You typically stop seeing this rash by 6 months of age. It is a blanching rash itself. It kind of reminds me more of a kind of a lacy rash, not like Fifth's disease, but a little darker in hue. But there are some pathological changes that you got to think of. One is cutis marmorta telangiectasia congenita, and that typically is an asymmetric change, or it's fixed and doesn't typically resolve with rewarming. So if you see that, I tend to think of it more as an asymmetrical cutis marmorta. Consider this diagnosis. So the next one we're going to talk about is a Mongolian spot. The official name of it is, the new official name of it is dermal melanocytosis. You tend to see this more in African Americans and our Hispanic populations. It's very rare in our Caucasian population. You typically will most often see them over the lumbosacral or buttocks area. They tend to fade over time. You don't really see them when they're in their teenage years. And it's caused by an accumulation of melanocytes that are deep in the dermis. They can be associated with syndromes, but they're pretty rare syndromes. So I'm not going to go too much into that. But the important thing for a Mongolian spot is you need to document these. You need to document where they are, and about the size, because these can be confused with bruising and can inadvertently get forensic involvement. So once you see these, document them, so that way everybody knows, hey, this has been there. This is not just a bruise. So next is a harlequin color change. This is typically a benign finding in infants. We don't really know the true incidence of it because the majority of times our infants are bundled. And so this may hide it, but it's expected that about 10% of infants have this. It occurs suddenly. It's typically dependent. So just like this baby is. And it can last anywhere from seconds to minutes. It can be very upsetting to parents to see this because they're like, oh my gosh, there's something horribly wrong with my baby. It can cross the midline. Typically it doesn't. It's thought to be secondary to an immature hypothalamic center that's controlling the vasodilation. So it's typically only in very young infants. And I don't tend to see this past the first week of life. So next is milia. This is extremely common. It occurs in more than 50% of infants. It's caused by retention of keratin in the dermis itself. You typically see this on the face, but you can see it on other areas. I tend to see it more on the trunk and the upper arms, but the face is where it's going to be most seen. Parents will typically think that this is acne. Um, it's not. It's just retained keratin. You don't need to do anything for it. It's just reassurance, and it goes away typically after the first or second month of life. Do not try and pop these. You can introduce infection. And like I said, it's not purulent. Just leave it be. Next is something that's kind of similar to that is miliaria cristula. This is a benign condition that's caused by a blockage of the sweat ducts. You typically see this when they are wearing tight-fitting clothes, which results in the blockage of the sweat ducts. These are extremely thin-walled. If you rub your finger over them, they will rupture very easily. You typically see it over the head, neck, and trunk because of the tight-fitting clothes. It can be kind of difficult to figure out unless you get very close, which is why I provided you a close-up picture of it. The treatment is just reassurance. This will go away on its own. It's a benign condition. Parents don't need to worry about it. Next is something similar to miliary cristula. It's called miliaria rubra. It's benign in nature. It's again caused by sweat duct obstruction, but it's more in the dermis than the epidermis, and so it gives it much more of a reddish color. There's some inflammation associated with it. You may get some pustules. This one tends to concern parents more than Christia. It's caused by lubricant. So if they're really putting a lot of lotion on the baby, or they're wearing very tight clothing, and the treatment is to put them in clothes that actually fit them, and not the ones that are like cutting their little circulations off. Stop using lotions. Occasionally you can use drying agents such as cornstarch, which just wicks up the moisture more than anything. But I tend to just change their clothing and stop using the lotions. And that's typically what you're going to see on your boards. I don't remember seeing anything about cornstarch on my boards. Next, you have nevus simplex. A lot of people will call this a stork bite. That's the common layman's term. It's on the back of the head / neck. If you see it on the front, typically it's in between the eyes. A lot of people will call that a angel's kiss, at least around here. So that's the kind of common lingo. They're extremely common. I bet you if you looked at the back of the head on one of your colleagues, you would find one. There's thought to be a genetic component with it, so they tend to run in families. You can ask parents if either one of them have it. It's caused by a capillary malformation. These get very red and pronounced when the kids get upset. They typically fade with time, much like hemangioma. And the treatment is just reassurance if the parents are concerned. Next, you have neonatal acne. The new term is neonatal cephalic pustulosis. We have to have big old fancy names for simple things now. And these are typically caused by sebaceous gland hyperplasia due to maternal androgens. It's a normal physiologic response. They typically occur within the first week of life. They resolve before the infant turns 6 months. Most of the time, the treatment is going to be reassurance for this. Tell them not to try and pop them. They're not typically going to be scarring, but if it's severe, you can use 2.5% benzoyl peroxide, but you got to let the parents know, hey, when you use this, it may irritate their skin the first 2 weeks. It may make it a little worse, and it can also stain their clothes. So you got to be careful with it. Most parents will get upset if you give them a treatment that stains their clothes, especially with our population, because they typically can't afford a whole lot of clothing. So keep that in the back of your mind. Next, you have transient neonatal pustular melanosis. This is a benign condition. We don't know why it happens. They may have vesicular pustules at birth, and they can occur anywhere on the body, but typically you're going to see them on the face, neck, forehead, and lower back. Um, for your boards, if they tell you that you do a punch biopsy of it and the staining of these little pustules comes back containing numerous neutrophils, that's going to be the key point for this one. It's the treatment's reassurance. You don't really care. Um, but just let the parents know that this is going to fade over time. It's not going to scar them. They're not going to have these little things forever. And I say the different, well, I say with the punch biopsy that you're going to have numerous neutrophils because in erythema toxicum neonatorum, if you do a punch biopsy of this, you're going to get eosinophils in this staining as opposed to the neutrophils before. This typically occurs within the first couple days after birth. It can be extremely upsetting for parents because they're like, oh my God, this looks terrible. It is extremely common. It occurs in well more than half of the kiddos. We don't really know why this happens, which, as common as it is, you would think we would have figured it out by now. But the treatment is just reassurance. Now, one of the pathological rashes that you need to know about is incontinenti pigmenti. It was formerly known by this German name that I can't pronounce, but this is a syndrome that can have a lot of different systemic involvement. It is an X-linked condition, so you're on the boards, you're only going to see this in boys. So if you see something like this in a female, this is not the right answer. So know that. Its presentation is within the first 2 weeks of life, and it presents with these inflammatory vesicles or bulla. They are typically in a curvilinear pattern. They may have some whorls to them, but then it goes through 4 different phases within the first 3 years of life. They can have CNS involvement, eye involvement. They can have skeletal malformations. This is something that needs to be referred to genetics, neurology, and ophtho. They need a formal eye exam at birth and then every 3 months until a year of age, because you don't want to miss the eye involvement of this because it can have long-term sequelae. The next thing you need to know about is a colloidal membrane. This exact picture was on my boards, so you have to know this. It's present at birth. It's typically a very thick parenchyma-like membrane that is encasing the infant. It is a variant of lamellar ichthyosis. Initially, you don't have to worry about this the first week of life. It's the second and third weeks of life that you've got to worry about this, because that's when this membrane is shed, and it's a shedding of the epidermal layer. So think of this, when this sheds, it's a burn. So these kids can lose lots of fluids through their skin. They are susceptible to super infections. So you almost need to have these kids in like a burn unit or in the NICU. So don't discharge this kid home, because they are set up for very bad sequela. You need to refer them to genetics to try and figure out what type of ichthyosis this is. You may want to involve peds derm in these kids because the treatment of it is karyolytics and systemic retinoids. So this is going to be a very subspecialized treatment. So get peds derm in early. I know this is a little different since we don't have them here, but this would be one that we might grant emergency privileges to kind of help us out versus transferring this one out. Any questions on baby rashes before we move? All right, we're going to move on. All right, next we're going to talk about rashes that are generally, I think of as periodic. Well, yep.
Hey, Dr. Norton, for the pigmenti, cognitia, whatever it is, I thought it was X-linked dominant. Um,
Yes.
I thought it was, so I thought it made it intrauterine, fatal for
Uh,
boys, intrauterine.
no, it's not fatal for boys intrauterine.
Okay.
It's not like Rett syndrome.
Okay. Maybe, okay. Just looking at something different then.
And I can look into that, but that's my understanding of it.
Okay.
And if it's wrong, I'll let Dr. Carney know to email y'all.
Okay. Sounds
Okay.
good. Thanks.
All right. Any other questions before we move on? All right, let's do this. So we're going to talk about contact dermatitis first. These are typically a group of conditions that create an inflammatory response due to an environmental agent. Ones that you are going to typically see in clinic is a nickel allergy. What's becoming more and more popular, especially in the private world, is contact dermatitis due to henna tattoos. These are typically going to be seen in your adolescent populations. Um, Treatments are typically like what we do in eczema, and they're typically just topical steroids. And then, but if it's generalized, you may have to do some systemic steroids. And you have to do these more than 2 weeks, and typically with a taper, so that way you don't have a rebound effect, which makes it worse. So the first one we're going to talk about is rheus dermatitis. A lot of people think this is as poison ivy. Uracil is the allergic substance in poison ivy. It's in poison oak, poison sumac, any of those type of plants. And it what it does is it creates a classic type 4 hypersensitivity reaction. That's the key thing you need to know. That's cell mediated. It causes intense pruritus and erythema. If it's on the face, you can get very significant edema. If it gets in the clothing and it's not washed properly, you can actually get it in the genital region, which also causes bad edema as well. And this rash can present in a lot of different ways, but the key thing is it's typically linear in the configuration where the plant rubs you. But you can get pustules on this, you can get papules, you can get plaques, you can get vesicles, bulla. Generally, the treatment is reassurance, try to do lubricants, lotions, that kind of stuff. If it's on the face or you're having significant edema or a very severe case, you can use high potency steroids. Low to moderate steroids, there's not a lot of data that supports their use, especially in resolving this. There's some thought that they may help with the itching some, so you'll see people prescribe them for that, but there's no data to suggest that they actually cause resolution quicker. Next is you have nummular dermatitis, nummular eczema. I'm not going to go into a whole bunch of atopic dermatitis just because we get a lot of that in clinic. But I wanted to talk about this one because this one can be a very difficult atopic dermatitis to control. It's an acute papovascular rash, and they typically have a coin-shaped appearance to them. They do not have central clearing. They are extremely itchy. Will oftentimes see a lot of excoriations, which can sometimes skew that coin appearance because of all the excoriations you have. And this can be very, 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 very difficult to manage. Um, you have to use high potency steroids on these. They do not typically respond to your typical um, atopic dermatitis. So don't start with like a triamcinolone cream or just putting lotions and ointments. Like you got to go for the big guns for this one. And even then, sometimes it can be very difficult, and they may end up needing to get referred to derm. Next is molluscum. It is a very infectious rash caused by a pox virus. This can be spread to person. Um, their characteristic and the buzzword you may hear on the boards is this is an umbilicated papule. They are typically raised. They can be very itchy. They are spread across the body due to itching. Um, Parents get often upset. They were like, "Can't you give me something to fix this?" Um, and typically, it's if they're really bad, you can cut them out, but that's not something I would recommend us do it. Um, you typically, if you're going to do that, I would send them to derm. But these things can last up to 3 years. So you got to, whenever you're talking to parents, you got to set them up that this is going to be for a while. If it's causing social issues, that's when I tend to refer these, as opposed to if it's just on the trunk. But if it's on the face or the hands and kids are starting to have self-esteem issues, or they're getting picked on, that those are the ones I tend to try and refer out or treat. Next, we have lice. Um, I can already see Jeremiah's itching his head, as well as some of the ladies, and Dalton would be doing the same thing if he was here. But there's three different types of lice. um, One of the type of lice is what a lot of us know as crabs, but we're just going to focus on head lice. um, and what they do is lice go through various stages, and when they um, replicate, they tend to lay their eggs at the base of the hairs. So, and a lot of people know them as nits. So that's where you've got to look to try and find them. If you are seeing nits out further in the hair, this tends to indicate a longer term infection. Permethrin is going to be your first line treatment, but lice are becoming more and more resistant to that. Um, there's a lot of different second lines, but the one I tend to think of is malathion. But you got to warn parents that this is a highly flammable subject or substance. So don't get them near flames or anything like that, because you don't want to catch their poor little heads on fire. If they don't want to do anything like that, the next best treatment is actually shaving the head. And we've actually done that before. If you see lice in an infant or child's eyelashes, this is very alarming. This should set all of your red flags off, because these are lice that are in the pubic area and are typically what we would know as crabs. And so you've got to suspect abuse in these kids. So they shouldn't be in the eyelashes or eyebrows. If you see that, get to call Dr. Lamb. Next is scabies. It's very common. You typically this can be through any demographic or socioeconomic class. They're very infectious. They typically burrow under the skin, which is what causes intense pruritus. But you don't typically see the rash until you've got more of a chronic infection. It peaks at 4 to 6 weeks. The rash may initially appear as like a fleck of pepper, and that's where you got a fresh burrow. Permethrin is the treatment of choice, and then you have to treat initially and then do another treatment 1 week apart. In infants, it can look very different. It tends to be more of a generalized infection. The common places that you're going to see scabies are on the inner digits of the hands, inner digits of the toes, along the belt line. That's where you're typically going to see it. If you suspect it in a child, ask the parent, hey, do you have any of these type things as well? Because a lot of times they will as well. And you may have to treat the whole family. The next three diagnoses are very typically are itchy, but they tend to look alike. So the first one we're going to focus on is urticaria multiforme. This is typically seen in very young kids, more infants and young children. These are not stationary. These are mobile, raised lesions that have a wheel-like targetoid appearance. They typically have a very dark center, but these are going to move all over the body. So one of the questions I tend to ask parents is, hey, have you noticed that they've been moving? Or are they typically in the same spot? They don't typically involve the hands and feet, which is a key thing. The most common cause of these is viral infection. It doesn't matter what type of virus, any of them can do it. Then it's more of a reaction to drugs. And if that's the case, you stop the offending agent. Your inflammatory markers in these kids are typically going to be normal. They're going to have normal white count, SAD rate, CRP. So that can be more reassuring. Treatment for this is reassuring. We don't typically do steroids for this. H2 blockers, H1 blockers, they are typically more effective, but this typically resolves in about a week or so. Next is erythema multiforme. This is what the classic targetoid lesion is like that you learned in med school. These can have fever and mildly elevated inflammatory markers, but the key thing here that differentiates this from urticaria multiforme is these are fixed. These are not going to move. They can last up to 3 weeks. This is typically going to be in your older individuals. Over 50% of these cases are in individuals less than 20 years of age. The most common cause is viral. This was one that you do treat with systemic steroids. And this is one that's rare to have facial involvement. You can have hand and feet involvement with this, but it typically does not have facial involvement. Next is a serum sickness-like reaction. This is typically due to a drug. This is an urticarial rash that can look similar to urticarial multiforme, but it doesn't move as fast. So it will move. It's not fixed, but it's not one that, oh my God, it was there, and then 6 hours later it's moved. This is typically moves very slowly. These kids typically look sick. They have high fevers. They have high inflammatory markers. This one can have oral involvement. They don't typically have sloughing, though, of their oral involvement. There's no blisters or anything like that. It's just more edema than anything. So that can help you differentiate that from EM and Stevens-Johnson. The treatment of this is stop the offending agent and to give antihistamines, and this will resolve over a few days to weeks. If you're confused yet about these 3 diagnoses, don't worry. I've got a nice chart for you. Here's the link if you want to be able to look it up, if you want to take a picture of it with your phone. But this is a way to be able to think through and work through the difference between the 3. It's a good little tool. Here's the reference for it. So just keep that in mind. Any questions?
Dr. Norton, is serum sickness something that has to be hospitalized or like observed overnight?
It's not necessarily, especially if you have a milder involvement, but it makes a lot of people concerned for Stevens-Johnson, and so they will tend to put them in there. But it's not something that you like an absolute hard stop. You have to hospitalize those kids. Any other questions? All right, we're going to move on to more baby rashes, but these are dealing with the booty. The first one we're going to talk about is irritant diaper dermatitis. This is the most common type that you're going to see. It's your standard diaper rash. It has a multifactorial process that's involved in this pathogenesis. It's typically caused by a combination of things. You get fecal bacteria that are involved with urine that then begin to break down, which lowers the pH, which then causes skin breakdown, which then allows excess moisture to get into the skin, which then causes a barrier kind of friction rub. And so it's a lot of different processes. If you get really severe dermatitis. It may present as Jaquette's, which is on the right. These are almost like punched out biopsies with nodules. Sometimes this can be confused for cigarette burns. So especially in the ED, they'll tend to get a little jacked up by this. You tend to use steroids in severe diaper dermatitis to help its resolution, but the mainstay treatment is just barrier creams. Don't go for, a lot of us use zinc oxide. Go for the 40%. Don't use the little itty bitty 20%. Really go for the big guns. And if you tell people to use Desitin, it's the purple Desitin. It smells like fish. It gets over everything and it's super sticky, but that's what really helps seal that barrier in. If it's really bad, tell the parents, if they can, to try and pat the child instead of rubbing, because that will just make it worse. This typically does not involve the folds of the skin, so it's typically only on the outside. So keep that in mind. As opposed to candidal or yeast diaper dermatitis, this typically is going to have a very beefy red plaque. It's going to have satellite pustules. This involves the skin folds. Typically, the history you're going to get is they've had diarrhea, they've had recent antibiotic use, or thrush. This can be a side effect of irritant diaper dermatitis. If you see this in an older child, you have to consider, does this child have new onset diabetes? If it's a complication of nystatin or they're having diarrhea, a lot of times you'll see us, especially in the hospital, prescribe something that's called triple paste. This is not the same over-the-counter triple paste, because there is a brand name that's called triple paste. What the triple paste is there's a lot of different formulations. Ones that we most commonly use here is nystatin, zinc oxide, and Maalox. Or instead of the Maalox, we use cholecystyrene. I'm a big proponent of cholecystyrene, as the bile acids are a major player in breaking down the skin. And especially in kids with diarrhea, they have a lot of bile acids that come out. So keep that in mind. It is very difficult to get cholecystyrene as an outpatient. Most pharmacies do not have it, and a lot of insurances won't cover it. So keep that in mind. So if you can give it to them in the hospital, order it in the hospital, give them a whole bunch of it, so that way they can take it home. Any questions about diaper rashes? All right, we're gonna move on because I'm running out of time. Next, we're gonna talk about infectious rashes, rashes that some of these are a little bit more old school, but with the anti-vaccine movement / hesitancy, you're starting to see these more and more. And if you don't know what to look for, you're gonna miss it. First one is measles. So measles starts with the classic triad of fever, cough, coryza. You have conjunctivitis. 1 to 2 days at the start of the illness, right at the prodrome, you're going to see the classic Koplik spots, which are these little bluish spots on the buccal membranes of the cheeks. So you got to look inside of there. The rash appears 3 to 4 days into the illness, is very blotchy, is going to be extremely erythematous. It blanches. It starts typically on the face at the hairline and then spreads downwards. These kids look sick. Kids can get encephalitis from this and even die from this. You can have long-term complications from this. The treatment, especially in a hospitalized child, is to give them vitamin A. This is the answer on the test. Because it's thought that a lot of these kids have a vitamin A deficiency, and this is typically seen in third world countries and where it was first noticed. So give them vitamin A. Vitamin A is in the MMR. So that's the treatment. Next is the German measles. It's similar to measles itself. The rash is typically not as erythematous. I like to think of it as measles' little brother. These kids are not typically sick. Fever is typically their first signs, and it's very low grade. Their rash is very fine in nature. It starts on the head and moves down. Complications from this are very rare. And it's like, well, why even talk about this, if it's not a big deal from an infectious standpoint? The big thing is this rash is, or this disease is very, very infectious, and it can have very serious side effects for fetuses. So you have to keep them away from pregnant women. If you think that a child has German measles on the wards, you need to make sure that no potentially pregnant nurses, residents, attendings, anybody go anywhere near these people. The rash typically clears in 3 days. So it doesn't last quite as long as the measles. The next is fifth disease. The official name is erythema infectiosum. This is caused by parvo B19. You typically don't see this in adolescents. This is typically your toddlers that you're going to see in. It typically starts out with like a slap cheek appearance. I mean, they're going to have like these nasty bright red cheeks. And then will spread and become more of a kind of lacy reticular rash. That's what you're going to see on the test. That's what Stallworth likes to say it as. It replicates in the red blood cell precursors. So you may have a child that has TEC afterwards. They may be a little anemic, but this is an infection that you have to pay attention more to in kids with sickle cell disease and pregnant women. In sickle cell disease, it can cause an aplastic crisis and can be extremely dangerous. Next is hand, foot, mouth. If you've gotten it as an adult, you know how much it sucks and is extremely painful as an adult. It's typically caused by the enterovirus class. As you know, Coxsackie is a enterovirus. This is not our new coronavirus, but it's Coxsackie A16A or something like that. These typically have both an enanthem and an exanthem. When you look in the mouth and you see these ulcerations, they are typically very shallow. They're not as painful as herpes. The more severe version of it. Oh, I'm hearing some feedback. Liz, mute yourself. But the coronavirus version of this is typically the more severe of it. It can involve the GU area, not just the hands and feet, as the exanthem. If you only have the enanthem, it's known as herpangina. So keep that in mind. Next is Giannotti crusty. This is a papular acrodermatitis. When it was first discovered or associated, it was associated with hepatitis B, but that has now been debunked. Just about any virus can do it. A lot of people think it's due to EBV as well. It's common in 1 to 6 year olds. These are very discrete, firm, lichenified papules. They typically are in an acral distribution. They don't typically involve the trunk. Treatment of this is supportive. Almost treat this like eczema. Don't refer this to infectious disease. It's not something that is infectious. It is a secondary reaction to most likely a virus. So it's just supportive care. All right, next is Roliosa infantatum. This is one that you will sometimes see get admitted to the hospital. It will be like, oh my gosh, this child has meningitis. They have high fevers. They will have neck stiffness. They don't have the rash at this point yet. So you get the fever very early on. They will appear ill. It's associated with HHV6. The rash typically appears after about 3 days, and your fever is typically effervescing at that time. The rash itself is is quoted as rose-colored. That's going to be what the answer for Stallworth on the test is. And it's an erythematous maculopapular rash, and it can last anywhere from a few hours to a couple days. Next is more of our zoonotic infectious diseases. Do we have any questions about the other infectious rashes? All right, we're going to move on. The first one you got to know about is your rickettsial diseases. The rash itself is a vasculitis, so it's not actually an exanthem. It's more of a petechial type rash. It starts on the hands and feet and spreads central. You have to treat this right away. Don't wait for serologies or anything, because this will kill you dead, as Dr. Hahn likes to say. The treatment, regardless of age, is doxycycline. Your typical labs are thrombocytopenia. You'll have elevated LFTs and hyponatremia. So if you see those three things, think Rocky Mountain spotted fever. If you don't treat this within the first week of life, doxy doesn't really work, and the outcomes are abysmal. Like they're terrible. So don't wait on your serologies. A majority of these kids do not have a known tick exposure. I think the recent literature I saw is more than 60% of them don't know that they've been bitten by a tick. Down here in the South, you also have to think about starry, which we tend to have a lot of, but you treat it like Rocky Mountain spotted fever. Next is Lyme disease. It's transmitted via the deer tick. We do not have endemic Lyme disease in South Carolina. So if they have not traveled anywhere, don't treat it for Lyme. Don't get serologies. The closest state that has Lyme is North Carolina, and it's only endemic in 3 counties. That's right, 3 counties of North Carolina. Majority of this is in the Northeast. If you are practicing in the Northeast and you see this, don't worry about getting serologies, just treat it. The treatment is amoxicillin. The rash begins as a red kind of papule. It'll enlarge to a plaque and get central clearing, but you may have a necrotic kind of center where the tick bit you at. And this spreading is known as erythema migrans. So keep that in mind. Any questions on tick rashes? All right, let's move on. So we're going to talk about rashes that mimic. If anybody can tell me the year this movie came out, I will give you mad kudos. Anybody? Anybody? All right, it came out in 1997. So I'm really old and know this kind of esoteric trivia. All right, so the first one is scarlet fever. It can look like a whole bunch of different things. It can look like Kawasaki's due to the strawberry tongue. It's caused by group A infection. This can be a skin infection, or it can be group A pharyngitis. They typically get a sandpaper type rash. They can have a strawberry tongue. They get something called Pastia's lines, which is a petechial rash. Stallworth loves it, but it'll also be on your boards. You'll typically see it in the antecubital fossa, also in the armpits and the inguinal folds. That's where you look for Pastia's lines. It can be due to impetigo. It can be due to streptococcosis, which I like to think of the infantile sinus infection, impetigo, or group A strep pharyngitis. Next is tinea capitis, or ringworm of the head. This causes a partial alopecia. It's not a complete. They typically have broken hair shafts that you can look at. It has which gives it its salt and pepper type appearance. Check for posterior and occipital adenopathy, also post-auricular. You have to treat this with oral antifungals, because topical antifungals do not penetrate deep enough into the hair follicles to treat this. So the treatment is griseofulvin. You have to treat it for 6 weeks. If you have to treat it longer than that, you need to get LFTs, make sure that it's not affecting their liver. You need to tell them to use selenium sulfide concurrently with the oral treatment. This suppresses spore reproduction and helps with it. If you do a hair pool test on this, it is going to be negative. So it's not like tinea fluvium. A complication that you can get from tinea capitis is a carry-on. It looks nasty. It can be purulent. It's very boggy. It is not an abscess. So do not IND this. Don't use antibiotics. The treatment is still oral antifungals, but you may have to do intralesional steroids to help this calm down the inflammation. Again, do not IND this. It can be very disconcerting to patients. They can have self-esteem issues. They can also be subject to bullying. So if it's really bad, try getting them into derm to do the intralesional steroids. Now, one thing that can be confused with ringworm is something called granuloma annulare. This is an annular type lesion that begins as a nodule or papule. It then extends to form a ring and maybe a little itchy at times. It typically occurs on the extensor surfaces of extremities with a preference over the joint. So you'll see it over the elbows, the fingertips, the knuckles, the knees. A lot of people confuse this with ringworm, and they'll be like, oh my gosh, I've given them all different types of topical antifungals and it's not working. That's because it's not ringworm. The treatment is observation, as this just resolves on its own. The next rash you'll typically see a lot in clinic, and this is typically you're going to see in the teenagers, is keratosis pilaris, or KP as I like to call it. It's caused by keratin pluggings of the stratum corneum and the follicular openings. Is typically seen in individuals that have very dry skin and can at times be confused with eczema. It's typically on the arms and sometimes the trunk. If it's on the face, you can get some telangic erythema. The treatment for this is moisturizers. You can use some urea creams such as Eucerin that can help break down the keratin. If it's really bad, you can use topical tretinoins, but they can cause really bad skin. You already are dealing with dry skin, and tretinoins tend to exacerbate that. So I tend to use them only in extreme cases. All right, we're at 9 o'clock. Any questions? All right, I don't hear any questions. So let's get this going and taking care of children. Y'all stay safe. Oh, that's all a question from Hemwalk.